Hello, we are the Association for Child and Adolescent Mental Health, or ACAM for short.
Thank you. I first of all have to say I need prompting in terms of timing because I'm very bad at that. I'm not at all like previous speakers, so I apologize in advance. What I'm going to say is that because I was not here to listen to the first two speakers, I'm really sorry if I do something and use sort of classifiers which are not really PC in this particular scenario. All I'm wanting to say is that my expertise doesn't specifically lie in suicidality or self-injury. I came into this field by chance, primarily because my expertise lies in pharmacology, and I see children with all sorts of conditions who are treatment resistant. And so in the in 2010, there was a call, and that was a time when SSRIs and anti-epileptics and stimulants and everything were being told, were being accused of increasing suicidality in children. So I won a $3 million grant from the EU to coordinate and run a project called Suicidality Treatment Occurring in Pediatrics, which was to see what is the relationship between medication prescription and suicidality. So we realized at that time that there was hardly any instrument that had been identified that had been specifically built for that purpose. Because when you look at the Columbia scale, that was completely for a different reason that it was used, and it was never intended to be used as a screening instrument at all. So therefore, our aim and mission became that we had to first create new instruments. It has to be online so that young people can use it. It has to be tested in medical environment, in psychiatric environment, those who are depressed, those who are not depressed, and in the general population. So that was the mission that we were doing, and then to look and see whether any medicines increase suicidality. So that was what the project was about. So that's how I got into this field, and I will take you through what happened since. And so in terms of the conflict of interest, I am the director of the company called Health Tracker, which is the one which provides the web-based platform. This is a platform which I developed along with Paul Greengrass, who's a professor of sleep medicine, whilst I was working at Guy's St. Thomas's in Great Ormond Street. So the IP partly belongs to the NHS. They get royalties back from any use of the system. I was the coordinator of the project, an FP7 project called STOP, and I received funding from a few companies who deal with molecules for rare diseases because I run the Rare Disease Center and I don't have access to these molecules unless you're working with the company. And so that's and I work with patient organizations as well. So this is what we do in terms of in any patient who comes into my team for help. What we do is that we actually have an integrated model where it's patient-centered care. We get a we use a biopsychosocial approach. We get all of the information that is there, that is needed. We collect physiological data using a device called the E4 at the moment. We've tried various devices and we're probably going on to checking out others as well. And what this does is that it collects information on heart rate variability, electrodermal activity, accelerometer data, temperature changes, and so on. And what we do is that on the health tracker, we've got a whole host of instruments. Depending on the kinds of patients we see, it automatically allocates the questionnaires that are necessary. And so the patient can do it, the parent can do it, the teacher can do it, the clinician can do it, and it automatically scores, and you get everything onto the screen. In one click, you get all information, multi-source information on a single screen. So that as a clinician, it becomes a lot easier for you to have the single screen in front of you, get all the information together, and then you can set the scene for what happens. And so, for example, we have medication side effects, you have neuropsychiatric symptoms, you have treatment response, how they respond to treatment, quality of life, burden in families, suicidality, for example. The STOP set of questionnaires are there, allocated according to a four-question screener. If they score positive on any of the questions or the 4 questions, then the rest of them are allocated. So that's the background to why I'm here. So this is a complex diagram to which I pinched up from another article. All we're talking about is when you're looking at suicidality in the broadest sense, whatever we call it, whether it is self-injury, whether it is self-harm, you have multiple drivers. And unless you've got a mechanism by which you can actually collect information on all of these, you do not know what drives the process for whom. Because it is completely illogical to think that you have one model for everyone. It does not work like that in medicine. And human beings are different. Different drivers exist for different people. We need to personalize it if you want action to be relevant to them. So that's really what the part of it is. This has only come out recently, but now when I look back on mapping what we've identified as drivers and we've actually developed instruments for, almost every single thing in here has been collected as information from the project. So if you're looking at it just in terms of suicide rates, it's not surprising 15 to 49-year-olds are the most common. Now, I think that even in the last 10 years, things have moved on in terms of if you're looking at completed suicides. So, for example, we now know that if a person has high-functioning autism, they are 8 to 9-fold likely to complete suicide. So, if we're not talking about attempts, we're talking about completed suicides. And I'm talking about having to investigate, as a clinician, I'm asked to investigate when someone attempts suicide or complete suicide within an inpatient setting. Now, 9 times out of 10, a completed suicide in an inpatient setting arises in the context of someone who's got high-functioning autism, either diagnosed, not diagnosed, or trait significant enough, because they seem to have this very deliberate mechanism of being able to camouflage issues, plan meticulously, and they seem to have a mechanism by which hopelessness seems to be dark as such. It's black and white. So trying to get hope into those individuals is far greater than in the typical neurotypical population. So therefore, and this is all the things that we've only realized very recently. So the one message I would say is that if you are looking at patients in your clinic, please don't miss suicidality in high-functioning autistic individuals who may smile and tell you in front of you that things are okay. And often, if you look at the data, they have told clinicians that they were suicidal. It's the clinicians who have not taken it seriously because the person in front of them has had an inappropriate affect because they're smiling, they're giggling, and that is because of the autism. And so if you are looking at risk evaluation using the glasses of a neurotypical patient, you will miss it completely because the risk, what you need to be looking at is ignoring what the patient looks like, listen to what the person's saying, take the family or clinician's view or siblings' view of what they think that the person's mood is, and then put it all together and you'll get a risk evaluation which is far more appropriate. And this is because if you look at the statistics, the number of people who are completing suicides is far greater than it should be in this population. And that's why I'm spending this spiel, not for anything else to do with the topic, because I think it's something which is very important to consider. So, if you look at the whole stress diagnosis model, and this is what in 2010, when we were developing the thing, we looked at. So we looked at all of these various factors. We made sure that we had, we were collecting information on all of that. And when you look at suicidality very specifically, there is an issue if you're considering a chemical, which is or a molecule that is actually somehow making it more problematic, whether it is montelukast, whether it's an SSRI, whether it is Roaccutane, it could be any of them. So the issue with that is the model which was described by David Nutt's then is that when you start a treatment, initially what happens is that the agitation might increase, and this is why anyone who remembers when the first time SSRIs came into the market with fluoxetine, I remember it vividly, the first month we had to prescribe it with benzodiazepine. That's gone, forgotten. And that is how it was marketed right at the beginning for us. But now we don't do that for very different reasons and good reasons probably. But the issue is that there may be an agitation that increases initially, and then after that, as by week 2, 3, it might come down and actually decreases, and so the net effect is good. But if you're looking at this line here, which is to do with suicide risk, you may actually have a period when there is an increase in suicidal risk associated. So in terms of monitoring, you need to do it differently. But what we don't know is whether all the drugs have the same profile. This is for SSRIs. We don't have a clue whether anti-epileptics have this, whether antipsychotics have this, or stimulants have this. They may have a completely different take on how it is. So what we ended up doing was we had to develop an instrument that could be used universally for any drug in the market to try and see how you can actually do that. And of course, the issue is that the mood improves much later than the energy improving. So when you have energy improvement, you can actually act on your thoughts. Now, that said, if you're looking at it from the perspective of technologies at the moment, you're looking at very different things, and I have not gone into the details of trying to show you what works and what doesn't work, because I looked at it and decided I was not the right person to do it, because most of them have never been tested in a method which needs to be done for mobile technology, because you have to do certain steps, and none of them have gone through it. So these are things, the web-based methods are there, the mobile methods are there, social networks and so on. Most of them have some evidence. Most of the people who are driving it are if they stuck to the guidelines that are necessary for an approval of a therapy or a treatment, they would not meet that. So that's the problem at the moment. It needs to be tested out further. Now, when you're looking at it from the perspective of suicide prevention aspects of it, you've got various things down here. And in this, again, most of it, what happens is to do with crisis management. Anything to do with crisis management, it doesn't matter how it's delivered. It could be through the internet, it could be through the thing to identify and so on. It's common sense. Crisis management help is whether you're looking at it, whichever model you do, it seems to have an impact in terms of things. So if you're looking at it, accessing peer support and safety plans are the most common aspects that seem to be relevant when it comes to using it. So if you're looking for an app, if you're looking for something, these are the aspects of it. Can you actually manage a good enough safety plan and a peer support mechanism within that context of it? And is it something that does not breach GDPR guidelines and actually have confidentiality associated with it? So those are high levels of scrutiny, and that's part of the reason why you do not have anything that has been given the okay for it, because they have not reached that level of thing as yet. So that's all I'm going to be talking about in terms of the literature out there, because unfortunately we do not have very much that I can talk very confidently about. So the study which is to do in this was, we had 6 countries involved, so we had all the countries listed there. And what the overview of the project was that we had one which was to do with developing a questionnaire which was to do with risk factors and protective factors and medication-related factors and suicidality assessment. So we had to develop 4 different scales. We had to validate them. And then it had to be on a web-based platform, which had to be valid. Then we had to use the scales in 7 different cohorts, so that we could say that the scales could be used in medically unwell groups, psychiatrically unwell groups, and in the healthy population. We then had the machine learning was done. And in these other things, this is as important, which I'm not going to be talking about here, but one of the things that we did was we looked at the largest databases available in the world, looking at VG-based databases, the WHO databases from Uppsala and everything. And we identified, based on the reports, how many of them had reported suicidality with a particular medicine. So we could identify the medication associated in children at different age groups, and surprisingly, there are many medicines that we use which actually reach the threshold for that. And then we use that information and incorporate it into the questionnaires as well. And this was a work package which identified how can you get good biological samples from people who who self-injure or self-harm. And we published on that. So you can get salivary samples with just a cheek swab to get good genetic data from them. But surprisingly, we found that if you were under 8 years old, you needed double the amount of saliva, because the shedding being different in terms of cheek cells. So therefore, these are things that are also there, which we've put into the and of course then there was training and dissemination as such. So we had 1,002 subjects in total, and we had 7 cohorts. Broadly speaking, these were individuals who were depressed. Half of them on fluoxetine, half of them on CBT. And this was because at that time we needed to identify whether fluoxetine made things worse and so on. But it was never powered to answer that question. This was to develop the instrument, the platform for it. Then we had psychiatrically unwell but not depressed, so most of them were neurodevelopmentally unwell. Half of them were on aripiprazole, the other on risperidone. And then we had asthma and respiratory illness, half of them on Montelukast. Montelukast was at that time, even now it's got a black box label for increasing suicidality. So that's because of its action on the interleukins as such. And then the others were non-Montelukast treated. And then lastly, in the general population, we collected 222 subjects at the same time. One thing to remember in suicide research is that if you collect normative data at a different time point as such, societal changes may be different, like we've been just discussing about the NSSI. There could be a difference in terms of the rates, it could be a difference of things. So we had to do it contemporaneously so we could actually say that there was a difference or not. So that's what that was about. So these were all the information that we collected online using the Health Tracker platform as such. So we had a suicidality assessment scale that assessed the acts, the ideation, the behavior, the planning, and whether how they aborted it, all of that. The risk factors were all risk factors that were known, and then resilience, what were the things that prevented them from acting on it, and then medication side effects. And this is the first time that there's been a very specific scale developed to look out for side effects that increase suicidality very specifically. So those were the things, and apart from that, as gold standards, we had looked at the Silverman, the Columbia, and then we had all of these depending on the patients, what patients had, and then we had an alert mechanism available on the system so that if scores increased too much, you could get an automated, the key clinician could get an automated email to alert to tell them this person's scores have gone up. And strangely, because for the project, we could not activate that alert because the ethics committee said, by definition, if you did that, you would change practice, and so therefore we didn't. But we developed the whole process, and it's all ready to, and it's being used in clinical settings at the moment. And then lastly, after all of that, we then use the data to using machine learning and AI to see whether we can predict who would enter. So the process of how we develop the scales, each of the scales as such, this is the FDA approved protocol, so that any instrument that follows this thing can be used in clinical trials. So what we do is you do a systematic literature review, identify the items and scales developed, then you conduct focus groups of patients, families, clinicians, everything. Then you modify the scales, then you get expert feedback, and we had an experts advisory board. And then after that, it's uploaded onto the platform, and then the patients have to approve the look on the screen, because otherwise if they're not going to use it, so it's useless. So everything had to be and they give feedback, and then the final product is what then was tested for test retest, 87 subjects. We ended up between 87 and 100 subjects. We did it within a week to 2 weeks to see whether the thing could change or not, and whether it was stable. And then the rest of it, we had more than 1,000 subjects in which we tested the whole model to see. And then finally, we did so we had exploratory factor analysis and confirmatory factor analysis and so on initially, then finally the So this is how the questionnaires look for individuals. This is just an example of how it is. So it was very easy to just tick and go. So it was, they could do it on their phone, they could do it on their iPad, whatever. So when you look at completions, that's the issue when it comes to trials. You can have the best system in the world. If it is not completed, you then get wrong outputs from it as well. So the thing is that if you're looking at it, we had from baseline to 1 year, so we're talking about 52 weeks that we had, and at the end point we had around 72% of people completing. So it was not too bad as such, and it was all of the scales as such. So the process was that you had a 4-item screener. If you were positive, you got the whole battery. If you were negative, then you skipped some of them and then you did certain other scales which had a shorter version of it, because before we got to this, we identified that when everyone did everything, if you had a 0 for all 4 of the screening questions, there was less than 1% who scored even on 1 item on the rest of the questionnaires. So therefore it was pointless doing the whole thing. And so that's what we ended up using as part of the decision-making model. And then you could use it to, what we have is that using the suicidality assessment scale, we could then impute what would be the score on the Columbia rating scales. Because the mathematical modeling was done at the back end, so that you could compare, if you use the stop scale, you could still compare what a Columbia rating scale would have scored if someone had done it. So that was also done, and then we could get the nomenclature either by Silverman or the CSA. So this is an example of the scale. So what happened was that we had a whole lot of suicidal ideation here, you had the suicidal behaviors, and then you had plans and things. So these were the 3 factors that came out in the suicidality assessment scale. Now, when it comes to side effects as such, we had a whole lot of items to do with medication-induced emotional dysregulation, psychotic or bipolar symptoms, and behavioral dysregulation. So these were the ones which came out from the whole thing. When it came to resilience factors, you had external and internal factors, and as you can see, you had internal locus of control and external locus of control. And then when it came to the risk factor scale, you had a whole lot of risk factors which are not different from what you would expect, but these are to do with relationships, psychosocial factors, stressful experiences, substance misuse, chronic pain, all of that. Now, the important thing is that these were all scales that was done at different time points so that patients we could collect the information. So this is just to show you how it would have appeared to them, depending on the 4 scales, depending on what the patient had. So, what did we find when we collected all of this data as such? The first thing is that when you're looking at it, suicidal ideation, when rated by adolescents, it did not matter which cohort you were looking at. All of them reduced in 6 months, and by 12 months it was much lower than a baseline. It didn't matter what you did. The treatment order in these 7 cohorts did not produce a shift. When it comes to the ideation, so this is suicidal ideation. When it is done by parents, is rated by parents, exactly the same thing. By clinicians, exactly the same thing. So, in other words, suicidal ideation as such, focusing on suicidal ideation as your main thing, probably will be useful in short term, but it really doesn't seem to be the main driver for what happens in terms of terrible outcomes. So overall suicidal ideation decreased in whichever cohort you looked at. So the final product from this STOP study is to actually have a profile of a patient like this. So you know this is the level of suicidal ideation, and so it shows green to red, and it tells you where it is and where the. So if you've got someone whose attempts has been in terms of lethality, then you know that you may need to do it. So it's rather than it just being saying that someone is having an SSI or self-harm or whatever, you actually have a whole profile of the person so that you can plan what needs to happen. Now, we had, as I told you, we collected data at baseline 2 weeks, 4 weeks, 6 weeks, 8 weeks, 12, 24, and 54 weeks. This was the data points. And if you look at it, this is to do with the fluoxetine versus CBT aspect. It's almost mirrors. These numbers in the thing are the number of people who had suicidal behaviors. That's really the numbers in each of these things. And you can see it doesn't matter whether you're on CBT or fluoxetine, it actually reduces and it seems to be better across time. But what is different is after 24 weeks, after 6 months, what seems to happen is the fluoxetine one continues to remain low, but the CBT one goes up. And that's a spurious effect simply because the CBT has stopped by then. So therefore, what I'm trying to say is that this whole thing about, this is a naturalistic thing, cohort study, it is not a double-blind controlled study, but what this shows is that in day-to-day practice, the suicidality, whether you treat it with, say, when you're depressed, whether you treat with CBT or with fluoxetine, it seems to help. But when the treatment stops, especially the psychological interventions, it seems to again go back up, at least in this thing. If you look at it in all the 7 cohorts, again, the only one that goes up is the CBT group, and everyone else is going down as such. So again, telling you that treatment is necessary longer term. You may need boosters. So it's not surprising, but on the other hand, this is how health services currently are programmed. You give them about 8 sessions, 12 sessions, and you think miraculously everything is gone. It's not going to. You're going to end up with more problems afterwards if you don't continue with boosters. So that is all that is to do with what we found, and I will. What I'm now going to talk about is using the data that we collected to see whether we could predict who attempted suicide versus who didn't. And because of the data I've shown you, we decided that suicidal ideation should not be a priority to predict. Suicidal ideation is too variable, it is too common, and it doesn't make much of a difference in terms of what's happening. What is most important is suicidal behavior. How many times have they attempted suicide, and how bad is it, and how lethal is it? And that's the thing that our focus was. And so what we did was, these are the 4 questionnaires that were there. We had data from all the 3 the raters. And what I want you to, and I will keep talking about, work package 7 was the patients who were on either aripiprazole or risperidone for non-depressed psychiatric conditions. Work package 8 is depressed adolescents either on CBT or fluoxetine. Work package 9 is bronchial asthma, either on montelukast or not. And work package 0 were the healthy controls. And that's just a nomenclature as such, and I'll keep highlighting it as we go along. What we then did was that we developed a differentiability score, which is basically, it identifies those items that differentiate suicidal versus non-suicidal subjects. It then calculated by computing the percentage of the given answers that the participants between the 2 groups, and then we developed a D-score. And then this is more the kind of thing that is used in the back end for machine learning. But what I'm trying to say is that it was something that we developed with a very clear, predicted strategy, as opposed to just putting everything into a pot and then coming up with something. So, just to give a very idiot's guide to what artificial intelligence and machine learning is that if you look at artificial intelligence, it is the study of intelligent agents. Basically, it's a design an intelligent agent that perceives its environment and makes decisions to maximize chances of achieving its goal. That's what it's supposed to be. Machine learning, on the other hand, uses algorithms, learning algorithms that build a mathematical model that's based on the data, that is the training data set that you give it. And in order to make predictions or decisions, it then can learn from the data you have, and then it can explicitly be programmed to provide a task. Now, in machine learning, you have 3 types. You have the supervised machine learning, unsupervised learning, and the third is the reinforcement learning. In the supervised learning, what happens is this is for classification as such. So this is, you are telling them this is what you are going to get in your model. Now you tell us what's the best from that. The second is the unsupervised, is when you dump everything in and the computer does it, and the computer spews out and says, you don't really need to know how we came up to this decision, but this is what our algorithm is, that it is this or that. So this is the black box part of it. And this is where the medicine as such, it is very difficult for doctors and clinicians to say, suddenly we're going to trust our judgment to a computer when we don't even know what it used to be able to come to that conclusion. And so this bit of the machine learning is more problematic. It's probably easier to use when you're using it for imaging, neuroimaging, or for retinal scans or things like that. But for behavioral work, it's far more difficult to do because it could be, the variability is high. Then reinforcement learning is that where you end up using the reward maximization strategy, where what you do is that you start off with the thing, and then you can add, and then you have an external person who's a clinician who dictates what the weight should be for what item. So it's the human who's actually still dictating and getting it. So what we ended up doing was that we dumped this because we said this was not something that we were interested in, because there's no way I was going to want to know that the computer does something and tells me this is A or B, and I don't know how it came to that because it is too problematic an area. So we decided we would go for the supervised learning part of it. And so what we did was we used the differentiability score and we looked at two things. Accuracy is the correctly predicted label of whether suicidal or non-suicidal by the total number of participants. The recall is basically correctly predicted label versus by the total number of the label itself. In other words, this is basically the sensitivity and specificity. So, if you look at this, if you just look at this work package here, this is to do with the neurodevelopmental disorders without depression. And in that, what you can see is that it separates out neatly into those who attempted suicide, where these are suicidal behaviors. This is not ideation, it's the behaviors that were calculated. And you can see that there's a difference here. If you look at these are the depressed individuals, again, you can clearly differentiate. In the medically unwell group, that is the bronchial asthma, again, clearly differentiable. And then this is the healthy population. You can actually see the only item that actually comes out of the thing is actually NSSI, just self-injury, which is without intent, which is quite, there's an overlap between the ones who attempted versus who didn't. And this is to do with, when you're looking at it from that, sorry, I should have mentioned, this is based on clinician ratings. When you look at it from an adolescent rating, you have slightly different variables but much the same pattern. It can clearly predict who would have attempted suicide versus who wouldn't, who did or didn't. And this is basically, the model was to develop the model in 10% of the data set. So only 10% of the patient's data was used to develop a model. Then we used the next 10% to improve the model. Then we used the next 10% to test the model and see whether we needed to improve it. By the time we got to 40% of the data set, we had saturated the thing as such. And so therefore, we then used the rest of the 60% of the data to test it to see whether the model worked, and it did. And that's what these data is. And this is, in a very simple thing, we removed the screen questionnaires, which would have said yes or no, and what we then found was that this accuracy is the same thing as specificity, and it is about 97%. In every, it doesn't matter whether you belong to the medical, depressed thing. And since sensitivity, again, is about 97%, and it's in the depressed group, there's a slightly different thing. But if you're normal groups and the medically unwell group, they're very similar, and you can predict with very great accuracy whether they're going to attempt. And we've done this, repeated this for just NSSI without intent to commit suicide. It's much the same model, where with different items though, but we can do the same thing. And again, when we use the same items across all variables, all raters, whether it's adolescent parents or clinicians, you can see that you actually, the model remains well. So the take-home message from this was that it did not matter that you had to get multiple ratings, because the model was able to predict just as well with even one person. Whether it was just the parent, just the clinician, just the adolescent, you had more than 95% accuracy in this particular sample. And I'm not saying this is going to be replicated everywhere, and I need to clearly state that, but at the same time, I was so shocked that the data showed this, that we tested it around 5 different times with 5 different methods of doing it, because I couldn't believe the data, and I still, I'm hoping that someone will be able to tell us if there was something that went there. So, last bit of my talk is about the wearables, and this is very limited because it's, and I'll show you why. So this is, we collect data from every patient coming to the clinic. This is data about a particular patient who had autonomic dysregulation, which most psychiatrists don't pick up. In fact, in my clinic, the commonest reason why there's treatment resistance irrespective of condition, it could be for schizophrenia, it could be for depression, it could be for things, is because we haven't picked up the fundamental autonomic dysregulation. And because the autonomic dysregulation has not been treated, neurologists never treat it because they think it's not the brain, it's this ANS, so the autonomic, so that's not their problem. The psychiatrists, on the other hand, don't really look at it because it's too data-driven and it's too thing as such. So you either end up with having woolly way of looking at things, or too precise, and it doesn't really work. And so the autonomic dysregulation is something that has been present, and we picked it up because I run a 80-bedded unit for acquired brain injury children, and there when you have brain injury, the first thing that happens is you end up having autonomic dysregulation. So that's how it came into it, so we've been monitoring it, and we've found that it's there. So this is, so what we've done is that we gave this particular child just 5 milligram buspirone, and you can see the red is the electrodermal activity after treatment and before. Now, this is the same thing when it comes to heart rate. You can see this is around 100 pre-treatment, and you can see that the majority of it has gone to the left, which makes it more adaptable for the child. Now, this is one particular case to just illustrate what can be done. You collect it longitudinally. You have 3 things that you're collecting: your heart rate variability as such, you've got the accelerometer, and you've got electrodermal activity. And you use the accelerometer data to actually calculate the artifacts as such. So, because if you end up running around, your heart rate is going to go up. So it's not going to be surprising. So the algorithm needs to have a mechanism of using data from one sensor to actually collect and answer the question in another sensor, because these are all collected through different sensors. So for example, this device collects the heart rate variability almost every 50 to 100 milliseconds. The Apple Watch, which I have, collects it every once in 6 minutes. And that's the difference. So in between the 6-minute data collection of heart rate variability, there's imputation being done by a model which Apple has. And so you look at your data as if it is correctly there, but it's actually being imputed in between. And that can't be used in cases like this. So this is just to show you what happens. So this is electrodermal activity at contact 1, 2, 3, 4. These are just chosen for patients to show you how it could be. And this is heart rate variability, and these are all the various different kinds of factors that you have: the PNN50, the mean maximum of the heart rate, and so on. And so this, you can see quickly as to why you need a full computational analyst team in as part of your team, because I'm not going to be able to analyze all of this. So we have, as part of my team, we have a digital analyst whose job is to actually do this and give us data in real time. So what I've converted here in the graph is that this is the electrodermal activity on a scale of 0 to 5, how bad it is. This is the green is the suicidality in terms of how bad it is, and the red is the heart rate variability, and this is depression scores. So what you can see is that if you don't look at it across time, you can end up with a false sense of having found an answer, because if you just look at the data here, you might end up thinking, oh, electrodermal activity is not really a problem, the suicidality and the depression is thing, and when this comes down, the heart rate variability is starting to come down. But the implication might be completely different from that. So the next thing to look at is, this is a child who we just assessed very recently, and what you can see is that this is just the first time point. And here in this child, everything is a 5. The heart rate variability is a 5, the most abnormal. The thing is that EDA is abnormal, plus the suicidality and the depression. So what we don't know is what's going to happen across time here. So if you look at 4, these are just 4 subjects. And what I want to just highlight is, when you're using wearables and technology, this is being done within the context of a 1-hour structured assessment in clinic. So we're not even talking about 24 hours data when it's they are walking around doing everything under the sun, and then you're making inferences from that. Because the variability is too high, the data storage is too high, the need to analyze is too high. This is to do with a structured 1-hour session in your clinic. When you're doing a clinic appointment, they just wear the watch and you collect the data. And even there you can see there are different patterns in that this person has increased electrodermal activity and heart rate variability, and here you have a completely different pattern. So my take-home message for wearables is that when you are looking at it, you have to be circumspect because you need numbers to be able to predict what kind of thing. And I just came the last bit of the last speaker's talk, and I think when it comes to all those different motivating factors which are being in the model, they may have very different perspectives as such. So to conclude, what we have managed to achieve is we've looked at all of the data available, we've developed instruments, we've actually got it online, we've actually validated all of them, they're all published now, and then we've done machine learning strategies to be able to try and identify prediction modeling, and we've got a scale which is just based on 20 items in the end, which takes a patient up to 5 minutes to 8 minutes to complete. It can be done on a phone, it can be done on anything. That's the product in the end. Now that has to be tested in the real world in patients as such to see what it is. And my take on the wearables part of it is that I think it's likely that you will need a hell of a lot more than we can actually provide in a thing, because variability is too high, and you may need to find a subgroup of individuals with high electrodermal activity and then focus on that subgroup to see what's common to them. And that's the pattern I think which will help in the long term. So thank you.
To be part of the advancement of child and adolescent mental health, visit www.acamh.org.